We will be discussing about new and emerging risk, innovations in CAD, and innovation in research and future directions. The new and emerging risks, what I will be discussing include lipid markers, the role of environmental pollutants, and the other different underlying mechanism in diabetes. Innovation care includes how best we can give the drugs to our patient. That includes family-based intervention, polypills, telehealth, affordable artificial intelligence-based care or digital health. Innovation in research include technology-based solutions for clinical care and interoperability issues. We all know the classical risk factors for CAD. We categorize them into modifiable risk factors, non-modifiable risk factors, and conditioning factors. The conditioning factors predominantly are associated with the low or low middle income countries. That includes poverty, education, stress, and lifestyle issues. The modifiable issues, risk factors includes behavioral and biological. We have discussed extensively about the risk factors in the previous previous session for doing last 2 days. And the emerging risk factors is environmental pollution. It should not be forgotten in a low middle income country, especially in a place like India where the air pollution index, if you look at go to the website air pollution index, most of the places are shown either as a red or as green. That we need to, as a group, we need to work hard to decrease the air pollutants along with the help from the government of India. So lipids, what's new? Cholesterol, we know the architecture, anatomy of cholesterol. It's made up of multiple cholesterols, cholesterol esters, phospholipids. The outer surface coatings, the green one shown here is the ApoB. The pale pink is the phospholipid and the yellow is the free cholesterol. And the non-polar lipid core includes cholesterol ester and triglycerides. What's new here? LDL actually has got 3 types, LDL type 1, type 2 and type 3. The type 3 is the smaller one and type 1 is the larger one. As the size of the LDL goes down, the amount of ApoB to the LDL actually increases. That's the point to ponder. So LDL and ApoB, triglycerides and ApoB, these are all the ratios that are evolving now. For in Indians, what are the differences compared to the Western population? For any given total or LDL cholesterol, the total cholesterol to HDL cholesterol ratio is definitely higher. We all know about it. That leads to increased heterogeneity of the lipid pool. And also, we all know specific small dense LDL fraction which is the LDL form 3, is also high in our population. What is the difference? Look at the figure on the top left. Top left, the LDL is a kind of LDL1, the mass is big, however the amount of ApoB is not high. The type 3, which is the small dense one, on the right side, you look at this is a small LDL, but the amount of ApoB is significantly on the higher side. As the ApoB goes higher, the chances, they are more atherogenic, the heterogeneity of the LDL becomes higher. This is the data that compares the difference between various cholesterol molecule in the US population as compared to Indian population. Almost all the factors are significantly different as compared with the US population. Most of us have got a bad dyslipidemia. What does the inter-heart study says as compared to Western population, South Asian? The ApoB to ApoA1 ratio is significantly higher in South Asian population. How about ApoB and LDL cholesterol in Indians compared with the US? The left figure shows the dotted red is the United States, while the continuous blue is the Indian population. If you look at any point of time, the given LDL value is slightly on higher side in United States. However, with the same amount of LDL, the ApoB is significantly lower with the US population and is higher with Indian population. So it is not the LDL alone; it is the amount of ApoB that matters. So this is the illustration figure. So it's not that your LDL is high, you may be having a significant heterogeneity. There are concordant, discordant ratio things that is going on here. A high LDL with a reduced non-HDL ApoB, the risk is not high actually. If your LDL is on the lower side, however, the non-HDL to ApoB is on the higher side, that means your atherogenic small dense is going to be on the higher side, you've got higher risk. If your LDL is high and your non-HDL ApoB is also high, you have got the highest risk. This is the point that we need to assess in the day-to-day clinical practice in our patient. In addition to achieving the LDL goal, I would say you should also think about achieving the non-HDL to ApoB ratio 2. There's no need to discuss further about this particular side. We started with the Scandinavian study. Now we have got Odyssey outcome. The lowest is better. LDL of less than 30 is the proposed lower LDL cutoff for extreme high risk by Lipid Association of India. The guidelines are still evolving. As recommended by ODC, if the LDL consistently goes less than 25, we may have to step down with the statin if the patient has got some side effects too. So ApoB is a single atherogenic lipid marker. It's present in all lipid fractions except HDL cholesterol. It takes the cumulative atherogenicity of a particular individual, unlike LDL, which measuring LDL alone, which misses the atherogenicity molecule which might be present in triglycerides and chylons. So ApoB integrates and extends the information from triglyceride and other cholesterols. The replacing conventional lipid panel with ApoB for routine follow-ups, that definitely adds cost to in our clinical day-to-day practice. But however, after explaining the due risk and better outcome, clinical outcome, if we are able to achieve ApoB, definitely we will be able to convince majority of our patients. We need longitudinal data, mechanistic studies, and point-of-care devices so that we can do a quicker assessment and provide a better care. In India, this space is going to extend, and we are going to have a significant amount of evidence from multiple studies that includes a multi-center registry that's ongoing in next couple of years. So this is the available cardiovascular health or disease continuum. We are primarily treating or diagnosing and treating the patient at the end of the disease process. The disease process starts slowly, multiple decades before. We need a system where we can definitely identify those high-risk individuals and target them and provide a precision therapy so that we can identify the problem much earlier and treat them earlier so that they don't go to the end phase or the late phase of the particular disease. The precision cares is a part of the study where we have multiple pathophysiology clusters like lipids, inflammation, adipokines, immune activation, thrombogenesis are being studied. Individual to population risk factors, air pollution, it's definitely a risk factor. And the recent study says there is the hazard ratio of having air pollution is equivalent to diabetes or even smoking. So sick individuals arise from sick populations. Environment determinants, predominantly it's air pollution. Other pollutions like noise and water pollution have also been described. This is a study published from one of my mentors working in Sri Ramachandra Institute, Professor Kalpana Balakrishnan, who found that the particulate material, if it is going to be more than 900 microgram per meter cube, that is twice the recommended values by Indian government, then the chances to have adverse cardiovascular events that include stroke goes significantly higher. So this is what, So how it happens? It increases the vascular stiffness, it causes direct damage to multiple organs, it increases the inflammation. So how do we study the relationship between the air pollution and cardiovascular disease? The study was published already by the group from PHFI where they assessed a particular area in Delhi. The pollution was measured and by specific equipments, and the intent and the particular patient's movement was also identified by utilizing satellites. So these studies are robust. This particular study was a very robust one. They identified that almost 2.7 times odd of having a CVD if your air pollution is going to be significantly higher. They also found that every 25 micron per cube meter increase in particulate material, it increases the blood pressure by around 3 to 5 millimeter, and we all know that increase in blood pressure even by 2 millimeter systolic is going to increase the incidence of stroke, heart failure and CAD. Achieving a national ambient air quality standards that can potentially decrease the hypertension by 15% in urban Delhi, and we know the equation that happens in Delhi, especially during the month of winter. So even reducing the PM 2.5 from current 100 to 75 can reduce the prevalence of hypertension by and the consequence of hypertension by 5%. With this, I would like to conclude my talk.